the presentation, I will then go through those questions and we will get those addressed. Again, the intent here is Elon will talk for about 50 minutes and then we'll open it up to Q&A after that. With that, I'm going to, first of all, introduce our speaker today. But before getting into that, you're going to hear from Elon, his review of 300 investigation cases here in Minnesota long-term care. You're going to hear about some very disturbing happenings, and this will really tell you exactly why Elder Voice formed in the first place and why we continue to work so hard to make sure some of these situations never happen to other people. It's a pleasure to introduce Elon Caspi. He's our friend. He's been involved from the start, and he is also a board member of Elder Voice Family Advocates. Elon has a PhD in gerontology and is a gerontologist and dementia behavior specialist, assistant research professor at the Institute of Collaboration on Health Intervention and Policy at the University of Connecticut. He's also founder and director of Dementia Behavior Consulting, LLC. He is the adjunct faculty with the School of Nursing for the University of Minnesota, and he is founding member of Elder Voice Family Advocates. He's also author of an upcoming book titled Understanding and Preventing Harmful Interactions Between Residents and Dementia. His work is internationally recognized. And with that, Elon, I'll turn it directly over to you. Thank you.
Okay, well, thank you, Chris, for the introduction and for inviting me to give this presentation. And also for Kate for your fabulous help with bringing this the content in this presentation from the 19th century to the 21st century. So I appreciate it. Again, one housekeeping item for today is that we prepared a 2-page document with a series of links to resources that accompany this webinar. So I don't want you to worry about writing down the names of resources or trying to find the links. They're all going to be included when the webinar is going to be posted online later on. So today we're going to talk about neglect, which is one form of elder mistreatment in long-term care home. Looking at the image on the opening slide, you know, we may never know what Charles intended when he painted it. I believe it represents nursing home residents and care staff. But when looking closely at this form of elder mistreatment, one has to wonder whether vulnerable and frail elders who are severely neglected in long-term care homes, which is their home, are truly seen as people, as human beings, as citizens with equal rights. One also has to wonder whether the people who care for them, vast majority women, are seen and treated as human beings. We will get to that later. We will also return to the issue of dignity, which is the state of being worthy of honor or respect, and to the concept of disregard of it throughout the talk. In many of the horrific stories that you are about to hear, I decided not to use the name of the long-term care home. My goal today is that the information shared would be used to prevent harm in similar circumstances, not to point fingers at one care home or another. Please consider using any information from this presentation today for those of you who are care providers out there in your staff training programs, because if together we can prevent one serious injury or death, this presentation would have been worth it. I'm also going to return, you're going to hear me repeating the term zero tolerance to convey a message that underlies this presentation. Zero tolerance for mistreatment of elders in long-term care homes. I want to acknowledge Elder Voice members who helped me with an early phase of this project. I also want to thank Lindsay Kruger and MDH investigators for their dedicated work in investigating allegations of neglect in care homes, a tough job. I want to thank Chris Sears for his dedication and talent in covering elder care issues in Minnesota. I want to thank Jennifer Siegel for working hard to secure permission for the photograph, the image of the photographs of the painting that is displayed on the opening slide. And again, for Kate, for her tremendous help with this presentation, and Cross, also working in the background and also on the dissemination of this webinar. Before we start, I want to recognize that, I started working in the aging field 27 years ago as a nurse aide in a nursing home where my grandfather lived. And so I want to make it very clear, the majority of staff and nurses are dedicated, hardworking, compassionate, and caring people. And yes, there are good and even excellent care homes out there. So this is a definition from the Minnesota Statute of Neglect. Basically, it's the failure or omission to provide care or services, including healthcare and supervision, which are reasonable and necessary to obtain or maintain health or comfort of the vulnerable adult. They're not a result of an accident. And also they are services which a reasonable person would deem essential to obtain and maintain the person's health, safety, and comfort in those care settings. Here's a definition of physical neglect: failure to provide services necessary for optimal functioning or to avoid harm. When looking at the Webster Dictionary definition of the word neglect, to give little attention or respect to the person, to leave undone or unattended to, and then an important concept of the disregard, which is to treat as unworthy of regard or notice. And better put by an older woman with Alzheimer's disease in an early study many years ago that I conducted in 2 secured care homes for people with dementia. She said, "I want to know that someone will be there for me when something happens to me." Now, there are various forms of neglect, and you can see them on the slide here, just to name a few: pressure sores, lack of monitoring and treatment of complex health conditions, unsafe transfers, medication errors, lack of supervision. So many of us are familiar with those types, but I thought it's important to put them as one list. Of course, there's others as well. And now we know that from research studies and other reports that neglect is prevalent both in nursing homes and assisted living residences. We also know that a major contributing factor to neglect of elders in care home is what I call inhumane and unsafe people-to-people ratios. We hear a lot about staffing levels and staffing ratios, important terms, but I honestly believe that we have to remember that these are people caring for people. And as long as we won't take good care of the people who provide the care and genuinely acknowledge and support the mostly women who provide the care, among other ways, in safe and humane staffing levels at all times, including evenings, weekends, and holidays, we will not be able to accomplish the goal of substantially reducing neglectful incidents. We have reviews of dozens of recent studies showing that half of nursing homes in America are understaffed, and at least 1/4 are dangerously understaffed. This means that hundreds of thousands of elders are currently, as we speak, receive care under conditions of dangerous staffing levels, meaning putting them in danger for their safety and well-being. And of course, we know that during the pandemic, the situation is even worse. Now, there's also well-documented devastating consequences of neglect, both in both of those settings, as one can read in those reports. I also recommend those of you who haven't watched the film, the PBS Frontline film, Life and Death and Assisted Living. I think it's important to watch it to understand some of the systemic gaps in this fast-growing but highly for-profit and weakly regulated sector in America and in our state, in the state of Minnesota. Now, there's also a series of reporting of barriers for reporting that basically create the conditions for neglect to remain mute. That the voice of elders and their families is often unheard. We also have to remember that only a fraction of neglectful incidents ever make it to the state survey agency, in our case, the Minnesota Department of Health Office of Health Facility Complaints. Now, we can see here that there are important barriers for reporting, from lack of awareness of the problem, lack of protocols for detection, concern by staff that will reflect negatively on their job performance, and concern for disciplinary action, concern that the care setting would be issued a citation, concern for adverse publicity, fear of lawsuits. And then, of course, a lot of residents have cognitive disability that may prevent them from reporting on neglect that they're experiencing. And of course, there's a fear of retaliation, not only fear of residents fearing staff member retaliation, but also family members' fear of retaliation when they are expressing their concerns about the care. And also some staff members also report retaliation by certain managers in certain care homes. This is a quote of a resident in a nursing home in Minnesota. One day she told a OHFC investigator, "I'm literally afraid of her. She intimidates. Are you sure nothing is going to happen to me?" Referring to a staff member, as she was reluctant to share what happened to her to the MDH investigator. Retaliation is real. It's a real force, and we need to do anything that we can to put important protections to minimize it and to respond to it adequately when it happens. Now, there's also conditions that may resemble neglect in elders that we need to be aware of. And here you see some examples of these on the slide. As many of us know, in 2017, the Star Tribune, Chris Sears of the Star Tribune, released a groundbreaking serious special report called Left to Suffer, describing hundreds of situations where residents were neglected, abused, financially exploited, many horrific cases, including sexual assaults of vulnerable adults in Minnesota. This was literally an earthquake in the long-term care sector in Minnesota in the fall of 2017, not too long after the Commissioner of Health stepped down from the position. We may never know the exact reason, but what we do know is that the Department of Health was unable to keep up with the fast growth of mistreatment complaints in the years leading up to the special report. Now, I want to quote Patty Cullen from Care Providers Minnesota. She says basically that care homes and care staff have zero tolerance for mistreatment of vulnerable adults. Zero tolerance. So we're going to talk about zero tolerance today. So if you look at this graph, you can see a 5.5-fold increase of allegations, various kinds of allegations of mistreatment and licensing allegations in home care and assisted living between fiscal year 2011 and fiscal year 2018. So if we are serious about zero tolerance, one would wonder what happened midway when the complaints got to a point where they nearly tripled themselves midway. where was the zero tolerance at that point? I'm just going to leave you with that question. When we all knew that the complaints are increasing exponentially during those years. Now, why focus on neglect? Well, at least in Minnesota, neglect is the most prevalent form of mistreatment in long-term care homes. Not only at the allegation level, but also at the substantiation level. And this is at least based on what we have on record. Now, I believe it was a few months after Left to Suffer series came out, former Governor Dayton said that the real responsibility falls on each and every one of the care providers in the state. They need to fix the problems, stop breaking state laws, and follow moral codes. And in March 2018, another very, very important report came out from the Minnesota Office of Legislative Auditor. They conducted a lengthy, in-depth audit of the OHFC, a 100-page report, which can be used as a basis for reform at MDH OHFC, which a reform that has started, but we are years away from fully implementing many of the recommendations in the report. One of the recommendations was to use investigative data for prevention. And the Commissioner of Health, in a letter appended to the report, to the audit report, said, "We strongly agree with the evaluation's findings regarding better use of complaint and investigation data for prevention." And the Commissioner, I really should thank the Commissioner for her leadership, not only during this horrific pandemic, but also for her efforts to reform the agency and fulfill the agency's mission to protect vulnerable adults in care homes. So she said, we spend 98% of our efforts responding to issues rather than prevention. And then she paused, and a few seconds later, she said, and I mean it literally. So how can we shift to proactive, data-driven prevention instead of being predominantly in a mode of reaction to systemic problems in care homes? Now, I actually visited the Minnesota Historical Society. We learned that there's hundreds of MDH investigation reports, and I flipped through them from decades ago, from the 50s, from the 1950s, from the 80s, and the same issues of neglect and abuse and financial exploitation have been documented by MDH investigators back then. So what are we learning from these incidents? Instead of compiling hundreds of investigations every year, are we historians of bad care, or are we really, really committed to using investigative data for prevention? With regards to, so CMS uses the term FTAG to represent State Survey Deficiency Citation when a nursing home violates federal nursing regulations providing care to residents. But interestingly, the old FTAG related to neglect and the new FTAG related to neglect, they are combined with other types of elder mistreatment, preventing us essentially from disentangling this form of elder mistreatment and learning from it at the national level with the thousands of violations that are issued every year by hardworking and dedicated investigators in 50 states. So that's a major, major issue for tracking for CMS right there. So with this project, the goals were really to identify a sequence of events, or what I call trajectories, resulting in harm to residents. What are some of the main patterns underlying neglect? And some preliminary, and I should emphasize preliminary directions for prevention, because this project is still a work in progress. So I was able, using data practice requests, I was able to gain access to 429 MDH investigation reports that were substantiated as neglect, both in nursing homes and assisted living across Minnesota. These are all de-identified public records, And I excluded 129 of them because they didn't reach the definition of serious bodily injury, which resulted in a data set of 300 investigation reports, resulting in serious bodily injury and death of residents. And the time period here is 2013 to early 2020, right before the pandemic began. So while the data here is mostly not investigations that were concluded during the pandemic, a lot of the lessons could obviously be implemented in the context of the pandemic, because we know that neglect continued to occur with the many stories that we're hearing in assisted living and nursing homes across the state and nationwide. So here you see a definition of serious bodily injury from the Affordable Care Act. It involves extreme physical pain or substantial risk of death. It could it could consist of loss of impairment of a function of an organ, or requiring medical intervention, surgery, or hospitalization. Criminal sexual abuse is also part of the definition, but out of the scope of this presentation. So I conducted a qualitative review of those 300 reports, and I abstracted many of them into trajectories, as we will see shortly. And I identified some preliminary patterns for prevention. Here you see a breakdown of the investigation reports by setting and by how many of these reached the level of serious bodily injury, which is represented by the acronym SBI, 161, and 139 resulted in death. But it's very important to remember that even if a neglect that was substantiated did not reach the level of serious bodily injury, a lot of emotional and physical suffering still could occur. Here you have an example of a resident with severe cognitive impairment that requires complete assistance with activities of daily living. Staff provides unsafe transfer. The resident falls. The resident crawls on the floor without underwear, on hands and knees with soiled bowel movement. And staff walk by without acknowledgement of the individual, watching TV, reading magazine, and leaving the area several times. All this was captured on camera footage. There were no attempts to assist the resident, according to the report, off the floor and change the individual's adult dependence. Zero tolerance. We talked about zero tolerance. Another employee assisted the resident only 3 hours and 49 minutes after the incident occurred. And the perpetrator falsely documented the incident and the care provided. So let's just think for a moment, how did this resident felt emotionally when he or she were on the floor for this time that must have felt like eternity for this individual. Here we have a resident with stroke who was assigned to have assistance with toileting during the night shift. The resident goes to the bathroom at 2 a.m. The over-the-toilet commode is too small. The commode legs gave out, and the resident became wedged on the toilet, could not get up. Calls for help using the pendant and screams for help. It ended up being another resident that went to find the staff who was asleep at the time. Now, guess how the resident was assisted eventually? It was the fire department that came around 5 a.m. to assist the individual out of the toilet. Zero tolerance, right? Here we have a resident with cognitive impairment on what it's called memory care unit. I don't like that term. We're caring for human beings, not memories, in a care home for people with dementia. The individual required assistance with hourly checks and assistance with ADLs that were not provided. The resident was repeatedly found soaked in urine and sometimes feces. It was so bad that the mattress had to be replaced. Developed UTI and hospitalized. Another resident was soaked in urine for nearly 20 hours, with fecal material spread on the bathroom floor. Zero tolerance. Here we have a resident who is 77-year-old who is attacked by a roommate and experiencing severe brain injury. MDH investigated and concluded that the allegation is not unsubstantiated, uh, noting that there were no history of altercation between the roommates, and that staff could not have anticipated the expected and sudden altercation. But according to reports, there were warning signs prior to the attack. The daughter, who was begging reportedly for change of roommate, said, I told them that if, I'm sorry, the resident said, I told them that if I have to spend one more night with this man, then I would kill myself. They still ignored me. And the daughter, who was begging for a replacement of a room for her father, fearing for his safety, said, how many times were we supposed to warn them? And by the way, the daughter filed a neglect lawsuit and she won the lawsuit. And this phenomenon of resident-to-resident incidents is a very prevalent and concerning one nationwide. I want to share with you here a documentary film that my colleague Judy Berry and I worked on, and it's called Fighting for Dignity, and it's available at Terranova Films, including continuing education units for those of you who want to use it for training of staff to raise awareness for this very, very concerning phenomena. And also my upcoming book on the prevention of this phenomena, which should be published, if everything goes well, this summer. And there's also the issue of understatement. These are citations that are issued by a state survey agency at a severity level that is lower than it should be. And this is based on federal comparative audit surveys that demonstrated it repeatedly. Here we have Gloria, who was 90-year-old at the time. She lived with Alzheimer's disease in assisted living care home for people with dementia. And the neglect that she experienced was not even investigated. This particular incident, others were. One evening while in bed, she called for help nearly 100 times over 39 minutes. She fell off the bed, and on the floor, she continued to call for staff help for another 143 times. At some point, she was heard crying, please help me, Lord. In total, she called for help 240 times over 1 hour and 38 minutes. Now, it's important to remember that the family paid $6,810 each month to receive safe care for Gloria. Zero tolerance. Now, the daughter, who became an activist, reflected on this incident. She said something is fundamentally wrong with the system that allows an elder woman, anyone elder, to be disregarded in this way. She said that her goal is to obtain the basic dignity and safety and care that her mom deserves. She actually met Senator Scott Dibble, who is a champion in advocating for safe care for elders in Minnesota care homes. She met with him, and it left such an impression on him that her report about her deeply personally traumatic story of her mother resonated with him, and he told her that he is pursuing an audit by the Office of Legislative Auditor of the OHFC to learn about how can we improve the oversight and enforcement of these neglectful incidents. And we've seen the report earlier in the presentation. Now, there's also neglect, as we know, during the pandemic. Here we have a resident with Lewy body dementia and assisted living memory care. In the family on March 18 last year, there was basically a lockdown and family visits were not allowed. The resident started to deteriorate in various ways, as you can see here. He lost a lot of weight. The care was not provided. He had an ingrown toenails and pain that was painful. He had 6 falls in 2 weeks, unable to walk, even though he was able to walk in the pandemic, shortly before the pandemic started. And now he required a two staff transfer. On June 8th, the daughter decided to take him home. And this is what she saw when she arrived. He was shaking uncontrollably. He was saturated in wet. He was bruised head to toe. He was moaning in pain. His genitalia was bright red and the skin was sloughing off. A healthcare worker who witnessed it said that it was a severe neglect. Now, this is still, to my knowledge, still investigated by MDH, unless it was completed, and I would love to know if it was. In any case, um, while reportedly, while the daughter is seeing her father suffering so badly, the director of the one of the directors of the assisted living entered the room and told the daughter reportedly, if you're taking your father, if you're moving him out to your home, you will be responsible for the remainder of the payment of his residency. And interestingly, a leader of one of the largest assisted living chains in Minnesota, where this incident occurred, who watched the Car 11 segment about this alleged neglect, described the daughter's allegation as misplaced emotions. And I want to ask you, where are the misplaced emotions when you're thinking about what the director had in mind when she walked into the room when June's father was suffering so badly? And by the way, the family paid $9,000 as every single month for the care that was promised and the safety that was promised for her father. And one has to wonder where all this money goes. And I'm actually serious about it. I think some state agency in Minnesota needs to start looking into where all this money goes. $9,000 to receive this, zero tolerance. And yes, if you look at the dictionary definition of fraud, it is the act of deceiving or misrepresenting. We all know about the famous tours when families, often in an emergency situation or crisis mode, receiving the tour in a hotel-like settings, assisted livings, with all the promise your father will be taken care of, your mom's going to be safe, and the place looks like a hotel. And then they take thousands of dollars every month, and then some families experience that. So somebody needs to look into that issue of common deceptive marketing practices in Minnesota. The daughter reflected on this incident. I think it comes down to the isolation, the loneliness, and ultimately the neglect. Our loved ones are dying not due to COVID-19, but due to isolation and neglect that is going on behind the scenes. This is one of the most painful and excruciating experiences of our life that will forever have a lasting impact on us. In one nursing home in Minnesota, where 103 residents died of COVID, there was a special report by the Star Tribune in December last year, and detailing a series of failures that contributed highly likely to many of those preventable deaths in this care setting that, by the way, to my knowledge, is owned by a private equity firm, which is a major issue in of itself for oversight and enforcement. So what do you think? Should we just disregard it and those deaths and grant this nursing home legal immunity? A lot of people don't know that even if legal immunity would have passed in the legislature in Minnesota, I'm sorry, even if legal immunity would not have passed in Minnesota, practically, in effect, de facto, COVID-19 liability shields are already in place, as we described with 25 reasons why this is the case in our piece that is linked to this slide. So here, moving to some preliminary findings in this project. Nearly half of the residents had some level of cognitive impairment, but many more had probably dementia, because we know that cognitive impairment and dementia are under-screened and underdiagnosed. Dozens others had stroke, Parkinson's disease, and traumatic brain injury. And many were medically dependent due to various complex healthcare conditions. Many were physically dependent on staff for extensive assistance with activities of daily living. So very vulnerable frail population. In terms of the general consequences on residents, tremendous psychological suffering, many ER visits and hospitalizations, including substantial healthcare costs that go along with it. Many decline in their physical function and condition. Many move to a higher level of care, such as from assisted living to a nursing home or to a hospice. Many experience traumatic physical injuries and deaths. Now, it's important to remember that to replace, so that as you review those 300 investigation reports, many of those employees that were found as the perpetrators of the neglect were terminated. They were basically let go, or they resigned. And it's important to remember that to replace a single care employee, it costs between $2,200 to $4,000. So another healthcare cost that goes along with it. And then there's the human cost of this individual perhaps crossing the street, so to speak, and starting to work in a different care homes with vulnerable population. Now, when MDH investigators conclude an investigation, they are classifying, they are determining who was responsible for the mistreatment. 77% of the 300 investigations, it was the long-term care home that was solely responsible for the neglect, for the severe neglect and deaths. It's actually higher than that because 8%, it was both the long-term care and individual. So now we're up to 85%. And this goes back to the accountability of owners and administrators and corporate offices of for-profit long-term care homes in Minnesota and nationwide. So it's very important to remember that. Now, the trajectories are a sequence of neglectful events resulting in harm. The most prevalent forms of neglect in Minnesota, at least based on the investigations, are neglect of healthcare and neglect of supervision. Here we have residents that were required to receive wellness checks that were not done. Several residents were found injured and dead many hours, 2 or more days after the injuries. A resident with dementia fell at night, experienced an arm fracture. Can you imagine the pain? Calls for help using the call button at close to 2 a.m., but left unanswered for 6 hours on the floor, only assisted by morning shift at 8 a.m. Now, these incidents that I'm describing right now, I should have said, are in assisted living residences. Lack of fall risk assessment and residents repeated falls and still no post-fall assessment. Unsafe manual or mechanical lift transfer against care plan, against clear instructions in the service plan. Several injurious falls and deaths. Residents with traumatic brain injury and stroke, required repositioning, not done. The resident's pressure source increases in size to the size of a cake pan, 25 centimeters by 25 centimeters pressure source. Experiences septic shock and dies. Zero tolerance, right? So where was the zero tolerance at 10 centimeter by 10 centimeter pressure source? Here we have a resident in a care home. Yes, please.
Elon, you asked to give a 10-minute warning when your time is up. So I'm doing that right now. Go ahead and continue.
Terrific, thank you. So here we have a resident in a care home for people with dementia. The catheter was not draining. The resident developed E. coli, septic shock, eventually died. Residents with diabetes, extremely high blood sugar levels, and several deaths. Residents with a large bulge on the stomach, moaning in pain, delays in recognition, experienced strangulated hernia, and the small intestine basically died, and the resident died as well. Residents with cognitive impairment in pain, metal object found in the heel, experienced infection, amputated foot, and died. Multiple medication errors leading to multiple deaths of residents. Here we have a resident with dementia on a secure unit, able to leave via an unsecured door by the dining room, falls off a flight of stairs, experienced severe injuries, and died. Resident with dementia exits via a second floor door, falls on stairs, experienced subdural hematoma, dies 15 days later. Resident with dementia, wellness checks not done, left the building unattended, found dead in a pond. Staff unaware for 18 hours. For 18 hours, I don't know how this is actually possible. for a resident with dementia that moves into a memory care unit, and the resident is found with the head wedged between the toilet and the wall, and the resident died. Residents with Alzheimer's found with a neck entrapped between the bed and the transfer pole, died. 3 residents with dementia in separate care homes at separate times, gaining access to cleaning detergent, and that was left unattended or unlocked, ingesting it, experiencing severe burns, and dying. Resident requiring monitoring for suicide attempts, no supervision by staff at night. The resident manages to break into a locked medication cabinet, ingest 85 doses of medications, in an attempted suicide. Resident with Alzheimer's disease, known to be up most nights, walks at night in a common area. Staff sleeps on the sofa, captured on camera, fell, experienced a femur fracture, and died. Resident with dementia and heart failure, staff failed to plug the heart pump at bedtime. Batteries depleted. The resident died. Resident with dementia engaged in repeated altercations with other residents, lack of supervision, several physical injuries, hip fractures, and head injury. Here we have a resident with borderline personality disorder and intellectual disability who managed to bang 2 large nails into her skull. And she complains about headaches and swelling of forehead, not addressed for nearly a month, until a CAT scan is conducted. And you can see in the CAT scan the 2 nails inside her frontal lobe. Only surgical removal and treatment enabled the resident to recover. If you still want to read about more incidents, you can read them in our report, Inhumane and Deadly Neglect, revealed in assisted living facility in Minnesota, and the link provided here. Now, let's go to some cases in nursing homes. Residents with a heart failure experiences changing condition around 4 p.m., including calling "Help Me God." There were delays in calling 911. The resident experienced septic shock and dies the next day. So nearly 5 hours of delays until 911 was called. Residents with COPD experiencing a CO2 poisoning eventually dies. Unsafe transfers, 16 serious bodily injuries and 16 deaths due to unsafe transfers that were conducted against instructions in care plan. Residents requiring foot pedals on a wheelchair during transfers. The foot pedal is not used on the way to the dining room. The resident fell forward, fractured the vertebrae in the neck, and died. Here we have a resident with stroke and mechanical lift transfer to commode that is done but left unsupervised while attached to the ceiling lift against guidelines. The wheels become unlocked, the commode rolls away, the resident falls, fractured legs, severe pain, and dies days later. Resident with memory loss, shower chair wheels defective, did not notify maintenance. 2 weeks later, of course, the wheel breaks. Resident falls, experiences subdural hematoma. Resident with dementia falls, hip fracture, unrecognized for 18 hours. It was only family visited who identified it, and the resident died 5 days later. Resident with cancer, chronic pain, received 20 times higher dose of prescribed pain medication. The resident found dead. So I'm going to skip some of the further examples here of gastric tubes that led to death and other burns that led to death, and resident on required diet, chokes to death after gaining access to a sandwich that was left nearby. Another resident who died on the way to an appointment despite major warning signs of oxygen stress. And I'm going to just move on here. You can read these cases a little later. Residents left unattended on the toilet against care plan, experienced injurious falls. 4 residents dying when the ventilator disconnected. The last 3 of them were in the same nursing home, 0 tolerance. And then kind of trying to wrap up the presentation. Yes, Chris, did you want to say something?
Yes, if you could wrap that up, thank you.
So the overarching theme of the presentation is that the vast majority of the psychological and suffering and physical traumas and death could have been prevented Here you have quotes from care professionals demonstrating that if only emergency care would be provided in time, some injuries and death could have been prevented. So contributing factors are lack or inadequate nursing assessment, omission or inadequate unskilled, unsafe actions, major communication problems and breakdowns, dangerous delays, and organizational factors such as unsafe staffing levels and lack of nurse manager supervision and guidance. Preliminary patterns are lack of basic nursing and risk assessment, lack of thorough and timely internal investigation, failure to recognize warning signs and significant change in condition, lack of basic care assistance and timely interventions, not following care plans or inadequate care plans, lack of supervision, secure units that are not secure, again, families left in the dark, discoveries by families or external agency providers, or during unrelated outside appointments, or not having or not following internal policies and procedures. In conclusion, one can't help but think about the disregard to the fate and suffering of vulnerable and frail elders in a subgroup of long-term care homes in Minnesota. In conclusion, we all need to work together to break the silence and dangerous normalization of elder neglect. And we need to ask ourselves, would we accept these horrific incidents in childcare settings? We need to hold owners and administrators of neglectful long-term care homes accountable. And we know that assisted living is barely regulated in Minnesota, as the commissioner recognized. And we know that the protections in law are only as good as the enforcement capabilities, which are extremely weak in assisted living in our state. We need to ensure that external agencies will be informed in time and investigate in time, as you can see on this slide. And we need to use legal tools that are available, such as reporting reasonable suspicion of a crime in nursing homes. And you have here a link to CMS memo, very important tool that is far from being used in our state. We need to train staff in recognizing signs of mistreatment to prevent harm to these individuals. And I also wrote a poem that is called The Promise, or the broken promise, if you will, of the trust that residents and families place in care homes to provide dignified and safe care for the individual. You have a link here with Chris Sandberg's father here. And also, I want to just close here and say that it is the human right of elders to live in safe care homes. This is the picture of Jackie Hourigan, the mother of Kay and Jean, she was verbally abused and neglected in a care home for people with dementia in Minnesota. So thank you for listening, and let's open for questions and discussion.
Thank you, Dr. Caspi. I would ask that people use the chat feature, which you will find at the bottom of your screen, and just enter your question, and I will go through them as they come in. First of all, I want to also acknowledge the many really excellent care providers that we do have, but we cannot ignore those who are failing our elders and disabled folks living in long-term care. The first question for you, Elon, please share your perspective on resources availability at the Office of Health Facilities complaints to fully investigate complaints and the challenges for the public to access complaint information. For example, compliant, not connected to facility in assisted living, but instead to home care license.
Well, and we can provide more information about that, how to access for family members, even for residents to access complaints. It's not easy to locate it. There's various issues with that. Even for technical legalistic reasons, the word assisted living is not included in the drop-down menu when a family or anyone, for that matter, wants to identify whether there was a substantiated mistreatment in a care home where a loved one is residing or considering that care home. The word assisted living is not included. The words home care is included there. So it's just basic things like that would make it easier for families to identify information, even to identify where the web page is. It's not a straightforward thing. We've seen it only also throughout the pandemic that even today it's not easy to find at this point, 11 months, 13 months into the pandemic, not easy to find information about cases and deaths in care home, even though it's now compiled and it's on the website, but it's, trust me, it's not easy to find it even on the situation update. So we can share more information based on what your specific needs are if you contact us after the presentation. But it is possible to locate those substantiated mistreatment investigations and other useful information on the website. It just takes navigation and some guidance. I hope this answers your question.
Thank you. Thank you, Elon. Uh, Another question, or actually a point to be made. The investigation of the report you referenced earlier in assisted living where daughter took her father home was completed on December 8th, 2020, and the findings were unsubstantiated. Do you have any follow-up to that?
Well, I'll have to read the report. I'm sorry, first of all, I really appreciate that. I was asking again, MDH folks, and I was trying to find this information. Again, I think it goes back to the first question, but I was unable to locate it. And so I appreciate learning about it. I will definitely read it once I can locate it. If someone has it, if they can send it to me, that would be great. And then we can look closely at it, because I read a 25-page report that the daughter who used to work as a death investigator wrote. And so it would be very interesting to find what is consistent and what is inconsistent with the many allegations of the daughter. And there's also other ways for recourse. You know, MDH is one way, but as we learned with the resident-to-resident injurious incident, there's other ways to pursue justice for elders when families believe that the investigation did not reflect what actually happened. And we know that this was during the pandemic, when both MDH presence at the setting with regards to investigation of mistreatment was limited, because they focused a lot on infection control. Only the egregious ones were investigated. We know that the ombudsman was not on site. We know that families were not on site for the longest time. So one question that I would raise is, to what extent, when was the investigation started relative to the complaint file? Because as we know, as the months pass by, it has become extremely difficult to gain access during routine time, let alone during pandemic time, to evidence to substantiate an allegation. Just keep that in mind. And I would be very curious to know about the timeline of the investigation as much as the content in the investigation report.
Thank you. Another question, are there any lawsuits against these assisted living and nursing home facilities for these deaths? And if so, how are they still in business?
Well, that's a very good question. You know, we know that generally lawsuits, you know, are not as common actually. So, you know, many family members, as you know, Chris and Jean and others, you know, to experience that trauma, vicarious trauma, a lot of families are emotionally depleted. Some of them are so harmed that they choose not to pursue that route. But my guess is that the majority of those 300 investigations, there were no lawsuits filed. I don't have the ability to track that, but maybe maybe Susie Scheller can help us with that, or others. But I believe that there's a lot of ground for lawsuits in many of those cases, as documented in many of the MDH reports.
Uh, Kathy Lavelle, you have your hand raised. Go ahead and unmute yourself and ask your question.
Yes, I'm wondering if by chance there's been any thought of having Chris Spears do a follow-up report on what has changed since he did his initial five-part report to put a new light on it so that it's not hidden behind doors and stuff.
Well, that's a very good suggestion, and we can, certainly bring it up with him and see whether he's able to do that. Uh, uh, yeah, he did do this extensive report on the Northridge nursing home, as well as other reports during the pandemic. But that's a very good question. There was a lot of focus on COVID-19, and obviously, rightly so. But there was also a lot of related and unrelated neglect and harm during the pandemic. Um, Unfortunately, because of the fact that MDH, under the guidance of CMS, were not conducting the routine investigations. They did only for the egregious one, and the ombudsmen were not visiting for the longest time, and families were out. It might be very difficult to gain access to information, but we do have these reports. I have on my fingertips, I have 429 reports that led up to the pandemic, literally up to the pandemic began. So thank you for that suggestion. Oh, wait, I'm sorry. I want to just add one thing. One thing that is very important that you bring up is the audit report by the Office of Legislative Auditor, the 100-page report I mentioned earlier. So MDH started the reform under the new leadership of Commissioner Jane Malcolm. However, due to the pandemic, they obviously were not able to complete the reform. There's a lot of recommendations in the report that could be done, including, by the way, improving the website and the commitment to transparency to family members and residents. So there's a long way to go and implement it. One just needs to read those recommendations. There's a long way to fulfill these recommendations. So my guess is that we are far from meeting many of the recommendations. Some of the recommendations were implemented, others were partially implemented, and others were not implemented. So there's a long way to go.
Another question here that I think I'll actually answer, and Elon, you can add to it. Why doesn't assisted living and nursing homes pay better and get a more competitive workforce and better staff? Meaning, why doesn't the state of Minnesota require this, knowing these deaths are occurring? You make a good point here, and I would tell you that, yes, they are terribly underpaid, and we would be supporting avenues to do that. But the regulators and legislators share responsibility here too, because we need to make sure reimbursement rates are fair. And so they can be providing the kind of quality care. A lot of facilities are trying to provide care, especially with those on elderly waiver or some other public assistance, and the payment for that care is very, very poor. There are a lot of legislative efforts to raise, quote, to a livable wage. This is going to require all of us to contact our legislators and let them know it's time to start valuing those staff and making sure that they're paid appropriately. Elon, do you have anything else you want to add to that?
Right. So in over the past 13 months, we heard a lot the term heroes. So we heard that direct care staff who provide care, nursing home, and assisted living are heroes. Well, they were heroes since the first day that the first nursing home was opened in America and the first assisted living was opened in this country. But this big word, which is totally accurate, they are literally the foundation and the backbone of the long-term care industry. But for decades, the word did not match the action. And what do I mean by that? As Chris mentioned, what we need is a living wage for these individuals. um, and that they won't need to use to go to do 2 or 3 jobs just to uh, finish the month and pay the bills. Many of them are single mothers, and many of them are immigrants, are struggling with other issues. And so, how do we really match the action with the words here? Not only with payment, but also with affordable health insurance that many lack, and also with sick leave and family medical leave rights, as well as safe people-to-people ratios. Because as I said at the outset, low and dangerous staffing levels for elders in care homes are cruel for residents, but they are also cruel for the women, mostly women, who provide the care to them. So we this was staffing levels has been the major issue, advocacy issue for 5 decades, and we all know that it drives a lot of the horrific neglect that we heard today. But the action did not match the word hero. It's time for action. It's time to put some meaning into the word hero if we really truly mean it.
I've got one more question, and then I'll have a wrap-up question here. But does the ability to obtain accountability for abuse, neglect, or exploitation decline significantly with the death of the resident?
Well, Susie Scheller can speak more to that, but there is a very, very problematic law in Minnesota. And I think it's better that she will describe it. I don't know if she's on the call, but something that has to do with survivorship. So if the individual passes away in certain circumstances, and we can provide more detailed and accurate information after the webinar, or maybe Chris can fill in, the family are not able to pursue certain legal action to seek justice for their loved one, which is when you think about it, it's outrageous. And at some point when I'll have time, I'll have to go and study the history of this law, because it will be very interesting to learn what was the rationale. What was the rationale? Is there a strong foundation, a moral foundation, legal foundation, and ethical foundation for such a neglectful law? And then it goes back to the term that I use, nested neglect. A lot of things are neglect occurred not only at the care setting, but because of factors that operate outside the care home, such as laws that are prohibited, such as this one.
Thanks so much. I have a wrap-up question. We've got a new assisted living licensure law that is going to go into effect August 1st of this year. How do you think that law is going to help address some of these issues that you have raised in this presentation?
Well, I think I'm going to pass that back to you, Chris. Because you're really in the weeds of it. I know I'm involved in a more general way, and I don't want to start saying things that will not represent the extremely hard work that you and other elder voice members and many other families across the state and other care advocacy organizations have put into this licensure and assisted living rulemaking that is taking place currently. So, it's tempting for me to jump in and say how it's going to do it, but I actually prefer for you if you can take that on.
That's fair. That was a leading question, no doubt about it. But what you reported on today is the heart and soul of why we work so hard for that assisted living licensure. Being the only state in this nation that did not license assisted living had to get addressed. And that new law is put into a lot of care standards that didn't exist before. It has a lot of other protections that are needed. It doesn't accomplish everything that we would like to see, but we will continue to be working on that in the future and addressing issues as we continue to go. And it's research like this that enables us to better understand what's actually happening and what the solutions may be that legislative solutions, be it policy solutions by the regulators, or working directly with the long-term care providers. But with that, thank you
Chris,
for,
Chris, can I just jump in and just add one thing to what you just said? It was very helpful.
all right.
So, kind of a broad overarching view, after reviewing 429 investigation reports that were substantial neglect in Minnesota, assisted living and nursing homes, one of the clear things that is happening, or should happen but doesn't happen, is that the nursing profession, these caring, loving, dedicated nurses and the nurse aides, but I'm talking about the nursing profession particularly, is oftentimes missing in action in assisted living residences particularly. And what we need to do, the vision that we need to see, given the massive change in the landscape of care needs and complex healthcare needs and dementia rates in assisted living in the state of Minnesota, what we need to see, that's the vision, we need to see full integration of the nursing profession, and I should add the medical profession, into the day-to-day care of residents, because the principles of and the ethics of the nursing profession go back hundreds of years. And if the nursing profession would be present and active as it should be in assisted living, I guarantee you that most of these neglectful incidents would not have occurred, because you would have the assessment, you would have the screening, you would have the early detection, you would have the reporting, you would have the documentation, you would have the involvement of the care providers in time, and the treatment and the alleviation of suffering in time, instead of waiting for it to escalate out of control into serious bodily injury and harm. So again, it's putting that zero tolerance up front, and not only after the fact, if you will.
Thank you very much. I think there may be a couple other people who would like to be voicing some questions or making comments, but we're over our time limit right now. So I would suggest just give me an email, chris@eldervoice.org, eldervoicefamilyadvocates.org, and I will get back to you with that. Thank you very much, Elon Caspi, for your presentation. Thank you to all of our guests, and we will stay in touch and be offering future webinars such as this. Thank you.
Thank you, Chris.